specific displacement, like we've got here with Barbara's first MP joints, not so much with the lesser toes, then I would focus on the joint that was mostly displaced. If we had a patient with a peaking hammer toe on the second joint, then I would focus on that both at the MP joint and at the IP joint as well. So this is where your role as a clinician is you'll make an assessment of where's the distortion and which joints do I actually need to work on. And typically, if you're going to focus on one particular joint, you would do the extend, rotate, up, down, side to side, and you would repeat it so that you had that tension on those tissues for how many seconds?
8.
8 seconds. Yep. So it may take 3 or 4 repetitions depending on the speed of operating. So stabilize the proximal joint. And that's literally grabbing hold of the foot and that'll be between your thumb and finger. Stand on the lateral side of the patient. Sometimes what practitioners do, although physically you won't be able to here with Barbara, but sometimes the feet are towards the end, practitioners will stand in between the legs. Given most of us are males here, I just think it's an inelegant way if you're working on a woman to be standing between her legs, because it's not necessary. So stand on the outside, the lateral side, stabilize with your proximal hand of the metatarsal head, then thumbs up position, joystick position for those others who are so inclined, grab hold of the proximal phalanx in between your thumb and index finger. Then what are we going to do?
Extend, rotate, up, down, side, side.
Good. And in Barbara's case, we would do that probably 3 times. Extend, rotate, up, down, side to side, so we get a total of 8 seconds. Side to side, opposite. Then simply go across to the second. Now, you're not going to see what's happening because my thumbs and hand are going to cover everything, but I'm grabbing the proximal phalanx between my thumb and proximal phalanx of my finger. Extend, rotate, up, down, side to side. 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 For some of you, depending on the foot that you're working on, your hands may not reach right across to this side. So if that's the case, I'd come across the other side and then just go the same way. Extend, rotate, up, down, side to side. And probably do 2 toes, however many you can reach, and then just stick the cum onto the side and you can work through it that way. That's what we do with the MP joints. Now, we're also, because we're in the first MP joint region, we're going to tackle the sesamoids. Everyone who's on this side, all come behind me because the sesamoids are on the plantar aspect. You won't see anything from over there. Okay, so, Chris, do you have your foot handy? Or is it hidden? No, that'll do. Yep, here comes one. Thank you. Great. So, where we have the foot structure, we've got the sesamoid sitting under the first met head. If the metatarsal deviates medially and the sesamoids drift laterally, relatively speaking, which connective tissues are actually going to be the ones that will contract in response to that displacement? Are they the tissues on the lateral side of the met head or the medial side? Lateral. Lateral, exactly. So, the sesamoids will tend to shift. Now, the sesamoids are wrapped in the sesamoid apparatus. It's next to impossible to isolate the individual sesamoids and get contact with them. What we're going to do is mobilize the sesamoid apparatus, and the restrictions will generally form on the lateral side, typically in between the intermetatarsal space. So the action is going to entail getting your 2 thumbs on either side of the sesamoid, like so, and you're literally going to push, hold, 2, 3, release. Push, hold, 2, 3, release. And so it's a push and hold rather than a massaging over the sesamoids. That's not going to have the effect of stretching or releasing the contractures on the lateral side. Make sense so far? Yeah. Okay. Now the trick is, how do you find the sesamoids? Because from a palpation perspective, it's almost impossible. If you have someone with complete atrophy of their fat pad, you can feel them. If you have a bulimic type patient, you'll feel them. But generally, it's difficult to palpate because of the fibrous fatty nature of the plantar tissues here. So your landmarks are where the weight-bearing skin and the non-weight-bearing skin meet. That's where the sesamoids sit. Typically, there will be a crease or a wrinkle. I'm not saying you've got wrinkles, but there is, as you see, if you just flex the skin, there'll be a natural wrinkle where the weight-bearing and non-weight-bearing skin meet. So you want one thumb proximal and one thumb distal to the junction of those two skin types. And place your thumbs in between in the intermetatarsal space. Then put your middle finger in between the first and second toe so that you can adduct the hallux while you're doing this. So what you'll see now is I'm getting my thumbs on the outside, and it's literally, for those of you who know where peas come from, they come from pea bushes, and then you pick the peas, they don't come out of a can, and you literally shell the pea out of the pea casing. So it's like this: push, hold, 2, 3, release. Push, hold, 2, 3, release. Push, hold, 2, 3, release. And that way you're stretching these tissues on the lateral side. Typically, it is the medial sesamoid that shifts and hits the intersesamoidal crest that causes the symptoms. But you cannot isolate the medial sesamoid to try and shift just it. So we are tackling the whole sesamoid apparatus, move the whole lot, and then both of the sesamoids will move to that medial direction.
Can I ask a question? What are you doing with your left index finger? You're rotating and?
Not really. No, it's just going wherever it falls. So I'm just holding, I'm making sure that I'm, with my middle finger, that I'm adducting the hallux.
Oh,
Okay, and this one, it could stick out. It's doing nothing, it's just falling into a comfortable position. You'll also notice my position is I've got to come down and lateral to get to this. Another option, it's not as specific, is you could stay standing and sort of hook your fingers into the sesamoid apparatus or the intermetatarsal space and then try and pull, 2, 3. It's not as specific, but it is something that I will teach patients to do for themselves. I would typically get them to self-mobilize the big toe and then push, then it'll be pull, hold, 2, 3, release. The thing you have to be careful about is that if they do have sesamoiditis and you push into the metatarsal, it'll hurt. So avoid doing that. You need to push across and hold so that you stretch these tissues in between here. That's the mechanics of what you're trying to achieve. Any other questions?
Would it be a wise idea to work with a flexalis and brevis?
Yes, it is. As an exercise, and when I showed you Liz's x-rays yesterday, that was one of the exercises, FHB, literally there so that you could start teaching them to get activation of adductor hallucis and flexor hallucis brevis so they can self-adduct the hallux. Very wise part of the overall treatment plan. You can already do it. Nice. Go again. Yep, perfect. That's good. All right. Terrific. Grab